Hi, I'm Nick Makwana. As Philippa said, I'm a consultant paediatrician in Birmingham, and just thank you to the Encephalitis Society for asking me to come and talk today to you. So I was told it was a small group, which is good. I'm just really going to talk through encephalitis from a medical perspective and what we do, how we diagnose it, manage it, and it is really time for you to talk as well. All right, so I don't mind. You can either ask questions as we go along, or we can ask questions at the end. I'm really pretty easy about it. Okay. I wasn't quite sure where people were with knowledge. I know some of you have had encephalitis. Some of you will have families who have had children with encephalitis. So I was really going to just go right back to basics, and we'll just move through that. Is that all right for everyone? Cool. Okay. So just a little bit about me. So I actually trained in University of Birmingham. Then I did my sort of initial junior doctor training in Birmingham, in the local hospitals. Then I came to Liverpool and did a research degree in meningitis, actually, but that obviously encompassed some encephalitis as well. So I got an MD from there, and then I went back to Birmingham, and now I'm a paediatrician there with interest in infectious disease and allergy. So let's hope the tech works. Right. So you're probably aware of a lot of this already. Encephalitis is really inflammation of the brain tissue. And to really make the diagnosis, we should be taking biopsies of brains. That's the real definitive, but obviously we can't do that, and that's not the right thing to do anymore. So we use a lot of tests to try and work out, and these are blood tests, lumbar puncture tests, which I'll talk about, and to try and see if you've got encephalitis or not, and if you have, what type of inflammation it is. The reason it's really important from a medical perspective is that treatment is effective the earlier it's started. So we know that certainly within 48 hours, if you get the medication in, you're going to have a much better outcome. And what happened is that when I was doing the research degree for meningitis, there was a sort of pathway, an algorithm that was put together to try and improve how quickly people could recognize and treat meningitis. And because that improved the diagnostic capability so well, the Encephalitis Society, together with a group of clinicians, including myself, put together a flow chart for encephalitis to try and improve people's knowledge and treatment of encephalitis, and therefore to improve prognosis. As you can see, it's not that common. It's 10 to 14 per 100,000 children. So what that actually means in the UK is a district general hospital such as mine will get about 1 to 2 cases per year. Okay, so it's not many. And in a large children's hospital, so for example, for us, it would be Birmingham Children's Hospital, but obviously there's Manchester Children's, Alderhay, you'd get about 8 to 10 children per year. So it's not a huge number, so you have to have a really high suspicion, index of suspicion, to think about it and then treat it quickly. And what I'm pleased to say, actually, is over the 10 years I've been doing this job, I think that has happened. I mean, I was on call over the weekend, and there was a young baby who'd come in with what was thought to be meningitis, started on antibiotics, and then one of my junior doctors rang me within 6 hours, actually, of admission. I said, should we be starting this baby on acyclovir as well, because I'm worried that could be encephalitis. I don't think that would have happened 10 years ago. So actually, people are thinking about it a lot more, and obviously we did start that child on treatment. So from our point of view, the guideline was for 2 reasons. One is to improve the processes of how we sort of diagnose and treat meningitis, and actually to improve healthcare professionals' awareness, because I think that was a key thing, that people weren't aware of it. And sometimes people are surprised about that, but you only see common things, and therefore people only recognise common things. And for medicine, a lot of it is about pattern recognition. If you've seen it before, you'll recognise it again. So you can imagine you may go through a whole year, 2 years, 3 years, but having never seen a case. So therefore, it's really important to have it into the forefront of your mind. So what are the causes? So for us, in children certainly, there's 2 main causes. There's the infective encephalitis caused by various organisms we'll talk about, and there's non-infective encephalitis, which is an immune response that then attacks the brain. So if we think about infective pathologies, then the most common one that we see is herpes virus. And I say common, the incidence of that is about 1 in 250,000 to 500,000 cases. So you can see it's still not common, but that is the most common. Then we have bacteria. So for example, meningococcus. So this is the one that causes the rash. When you put a tumbler test, it doesn't go away. That can also cause encephalitis type picture. Parasites. So certainly if you travel from abroad, we'd be thinking about malaria. And then fungi as well. More so in children who haven't got a fully working immune system, fungi can also cause encephalitis. So you can see there's quite a variety of organisms that can cause it. And we do have ways when we talk to patients of trying to distinguish which one it might be. And we'll come back to that as well. The non-infective are quite difficult. So this is often where you've had an infection. Your immune system then mounts a response to that infection. And then what happens, those antibodies that your body has produced start attacking the brain tissue. And then you get this non-effective encephalitis because it's still causing inflammation, but not because of an organism. It's your body's own response to an organism that's caused it. So the symptoms, and again, many of you will be aware of these, is first of all fever. But actually what we found out over time is a lot of children haven't had a fever despite having the other symptoms of encephalitis. And that's why it was often missed, because people say, well, it can't be encephalitis because encephalitis is an infection and you haven't got a fever, therefore it's not encephalitis. And actually when we look at data, about 70% of children don't have fever, or they may have had a history of it, but not at the time they were seen by the health professional. And that's why it was missed. So again, that is an important symptom, but not necessarily the only one that's important. So altered behaviours, again, very important. A lot of these parents say that, you know, my child is behaving very differently, oddly, not doing the things they used to be doing. Their personality changes. And the consciousness, they sort of become very drowsy and lethargic. And again, that's a very important sign. Nobody would miss new onset fits. So if your child suddenly started fitting, again, that will be a very important sign as well. And when we come to examine the child, we'll be looking at abnormal examination of the nervous system. So they might not be using an arm, a leg, they might be behaving inappropriately, they might be very, very drowsy. And we measure drowsiness by something called Glasgow Coma Score. So we basically score a child, and if you're fully, like we are here today, you'll be a 15. And if as you get drowsy and drowsy, your score drops. If you've got a low Glasgow Coma Score, that would worry us that something else is going on. The problem is a lot of other conditions can cause exactly the same symptoms. So, for example, having a very high fever in a young child, just having high fever, no other reason, could just be like a flu-type virus, can alter your behaviour, can make you feel a bit drowsy. And certainly in children under 6, you can get a fit just because of the fever, not because of encephalitis. So again, it's trying to distinguish which of these symptoms are related to that very rare occurrence of encephalitis compared to very common occurrence of, for example, febrile illness, febrile convulsions. So that's the kind of things we'll be looking at and thinking about when we see a child presenting. And obviously when we're examining, that's the kind of areas we'll be, again, thinking about. So how might we distinguish between the different types of encephalitis we've just talked about? So certainly in adults, a cold sore is just often activated because you're unwell. So it's not a very good sign that you've got herpes encephalitis. So in children, though, we would think that if you've got a cold sore, that might be a idea that you have got herpes encephalitis. Because remember, the cold sores are caused by the herpes virus. And the problem with a cold sore virus is that it stays in your body forever. It doesn't ever go away, but it's activated when you're poorly. If your immune system's not working properly as you get older and your immune system declines, it can become reactivated that way. Chickenpox. So probably the second most common cause of encephalitis in children is chickenpox virus. So obviously we may have a history that you've had the chickenpox rash. There may be contacts in the nursery in the home with a chickenpox rash or chickenpox itself. So again, that would make us think more about could that be the underlying cause. It's treated slightly differently, and we'll come back to that. So chest infections. So I talked to you about bacteria causing encephalitis. There's a certain bacteria that if they're in the chest, they'll also infect the brain and cause encephalitis that way. And one of those, just for naming, is Mycoplasma pneumonia, which is a very common one that can cause chest infections and encephalitis. The glandular fever virus. So again, you may have symptoms of glandular fever, swelling of your neck, sore throat, and particularly so in immune compromise, so people whose immune system isn't working, that will cause encephalitis. Some of the bugs that cause tummy upsets. So we've got two particular ones, one called rotavirus and one called enterovirus. Those are both viruses that cause tummy upsets, but they can also cause encephalitis. And certainly in the last 5 years, I've seen one child who presented with new onset seizures, had encephalitis due to a rotavirus infection, which is actually a tummy infection. So that's extremely rare to find. And then obviously we'll be looking and thinking about rashes for lots of reasons, because many of those infections will cause rashes as well, including the viruses I've just talked about. So there may be some clues when we're examining the child, but there again, like I said, there may not. And some of these rashes can be caused by very innocuous things, not necessarily encephalitis. So you can see how difficult it can be to diagnose. But if we are suspecting encephalitis, then we need to do some investigations. And these are sort of the main investigations we'll be thinking about. So the one that all patients should have is a lumbar puncture. So, I mean, I didn't ask actually, how many of you have either had encephalitis? So if you've had it, and how many have got family members who've had it? So there's a number there. And are the other people health professionals or allied? Yeah, okay. So you will know probably what a lumbar puncture is then. Did you have one? Yeah? Yeah, okay, yeah, you probably will remember it, so you probably quite well at the time. And this is a really important test. So people get very worried about a lumbar puncture because they think we're going to go into the spine to look for fluid, but actually what a lumbar puncture is there to do, right at the bottom of your spine is the spine ends a bit higher up and there's a little bag of fluid there which is attached to the fluid around your brain. So actually when we put a lumbar puncture needle in, we're going below the spine, so not actually going to hit the spine. And I think that's the sort of question I hear from patients quite a lot. Oh, we're very worried it's going to cause paralysis, but it won't do. And really, that is the definitive test for us. Because what we're looking for when we take that fluid off is, firstly, if we've got white cells in there. Obviously, if you haven't got infection, there shouldn't be any white cells. But when you've got infection, the white cells are the cells that are produced to fight the infection off. So therefore, we'll see white cells in there. We see protein. Now, protein normally is really not very much in the what we call cerebrospinal fluid, or CSF. But when you get infections, it goes up, it raises dramatically because a whole load of proteins are released to try and fight the infection, which then enter the fluid around your brain. And they also measure glucose, because a lot of these bacteria and viruses need glucose to thrive and grow, so your glucose drops quite dramatically within the fluid around your brain. And you might be thinking, well, how come we don't get infections more often than around the brain? Actually, what's very clever about the human body is that it's got what we call a blood-brain barrier. So there's a very clever film across the whole of the brain, which is consisting of special cells. And these cells prevent germs, toxins, all sorts getting in most of the time. But occasionally, because of inflammation, because your immune system isn't working, actually what may happen is that the blood-brain barrier fails, and that's why the germs get in. Okay, and so the other thing obviously we'll be looking for in there is the germ itself. Now, we have very clever ways now of looking for germs, and we're looking at germ DNA, because often what's happened is you're quite poorly when you come in, and you can't really do this test when you're really poorly. Okay, because it can cause more problems. So what we normally do is start the treatment before we can do this test, which is often done 2 or 3 days later. And what happened in the old days is obviously if you started the treatment, the germ is killed, so you can't grow it anymore, so you can't actually get a positive diagnosis. But now what we can do is look for bits of DNA of the broken germ itself. So even though the germ is dead, we can still confirm that's the diagnosis by looking for that DNA. And that's what we tend to do now, and that's called PCR, if you may have heard of that. And the things we tend to look for is herpes virus, we look for chickenpox virus and enterovirus. They're the common ones we look for, and we may look for others depending on some of the presenting features that I've talked about. The problem is no test is 100%, so even if you have got that infection, it may not come up positive. So we do look for evidence of those germs elsewhere. A lot of these germs can live in the throat just naturally, and obviously we've already talked about some of these germs coming out through the tummy, so we do rectal swabs, so that's the swab of your bottom. And then if you've got the chickenpox scars or vesicles, we will actually take a swab from that to see if we can grow a live virus from there. So we are looking for other ways of trying to isolate what the cause might be. Scanning of the brain. So the scanning of the brain, a lot of people used to do this before they did a lumbar puncture because they thought you had to do a scan before you did a lumbar puncture. And that's why lumbar punctures used to be delayed quite a long time, or indeed sometimes not done. But what we know is that what you're looking for really when you're doing a scan is 2 things. One, is this something else? Is it an alternative diagnosis and not encephalitis? Or is there something that's going to stop me doing the lumbar puncture? Okay. But what people then ended up doing was just doing the scan to make sure it was okay to do a lumbar puncture. But actually there's very clear guidelines on when a lumbar puncture shouldn't be done. And most of those don't rely on CT scans. So actually you shouldn't be waiting for a scan, which could take a while, before you do your lumbar puncture. And what's happened over time is, again, people have understood this and people are doing lumbar punctures much quicker than they used to be, and therefore we get much better at diagnosing encephalitis than we used to. But if you do a CT, you may find it abnormal early in an illness, particularly for herpes encephalitis, or you might find alternative diagnosis. So then you might not need to continue with your encephalitis treatment and go down an alternative pathway. We tend not to do CTs if possible anymore because, like I said, they don't really help us make a diagnosis and they're not there to help us decide whether to do a lumbar puncture or not. And they do, the CT actually uses radiation. And it's quite a high dose of radiation. And what we know now over time is that even having a CT and having that amount of radiation can affect your learning and can affect things going forward. So we try not to do it unless we absolutely have to, and sometimes we do. And it's again thinking about what the benefit is outweighing any potential risks. What we would prefer to do is an MRI scan. Now, MRI scan does not use any radiation, and it's actually done by magnets. So it just basically excites the water in your brain, and depending on what the water is like in your brain, it will produce different kinds of pictures. So this is actually an MRI scan of a herpes encephalitis, and what you can see here, this is the abnormal part, and this is a normal part of the brain. This is the abnormal part, and this is inflamed parts, inflamed what we call the temporal lobe, all right? So there's two temporal lobes, and they're important for speech, language, and memory. So you can see why some of the long-term effects may be caused by inflammation in these areas. So what you're seeing is these water molecules looking different because they're inflamed compared to the rest of the brain, which isn't. Okay. And like I said, the reason we like doing the MRI is you get much better diagnostic certainty because this is, if you see this, really it's going to be very unlikely to be anything else, and it doesn't use radiation. So again, it's a better test for us. And then you may have heard of the EEG, or some of you have heard of the EEG. This is the brainwave test. We don't really do this for diagnostics. We may do this if we're uncertain, because the problem with the EEG is all it tells you is you've got what we call an encephalopathy, i.e. your brain's not working properly, but it doesn't tell you why. Okay? And it won't give you a definitive kind of diagnostic plan, or we won't be able to recognise what is causing the encephalitis just from an EEG. All it'll tell us is your brain is inflamed, which we know because of the way you've presented to us. It can be useful sometimes if you're, again, not sure about the diagnosis and you're thinking, do I need to do an EEG to see if there's something else going on? Yeah, of course, yeah.
Sean had quite a few EEGs, and they said they were doing them because if he had a seizure while they had the pads on, they'd see it on the reading. Surely that would help.
I suppose it depends on the seizure itself, because what happens with the EEG, so for example, if we think about EEG in epilepsy, to diagnose epilepsy, we don't use EEG to diagnose epilepsy, because if you do them between fits, which could be very long periods between fits, they're completely normal. So even if someone comes tells me, oh, I've had a fit, I will listen to the patient rather than the test, because the test, when I do, will be normal. So it depends a little bit on how he presented, or how you presented, why they would have done it. Because sometimes what we have very drowsy children, and we're not sure, is this what we call subacute status, i.e. is there fits going on in the background which aren't obvious because they're not shaking in a typical way and they're just making you drowsy, or is there something else going on? There used to be certain findings on the EEG which were thought to be related to herpes, but now we realise they're not. So actually there's no pattern on the EEG that will give you diagnosis of encephalitis, but it will give you diagnosis of seizures, if you're uncertain, or encephalopathy, which then may take you down, could this be encephalitis? Do you know what I mean? So it depends slightly on when the presentation was, how you presented, whether it would have been useful or not. But it wouldn't necessarily have diagnosed encephalitis. It might just help them think about it, or it might help treat seizures. Does that make sense? Okay. So once we've either thought about diagnosis, obviously we don't want to be waiting for the test because those PCRs can take quite a long time to come back. So as soon as we've sent our tests off, or we've worried enough that this is encephalitis, we will start treatment. And the treatment that we will start based on the most common cause of encephalitis, which being herpes, is a antiviral medicine called acyclovir. So that is the treatment that we would use for herpes. And if it's chickenpox encephalitis, we'd use it for that as well. It's given within 48 hours. Really, we tend to give it within 6 maximum, but 48 hours is a threshold period where you've got a bit of leeway to get it in, and we know that your outcome is still okay. Any longer than that is a problem. And it depends on who you ask and what you read. Some people say 10 days enough, some people say 14 days enough, some people say 21 days is enough. What we know for definite is that you get higher disease rates recurring in children. So 3 months old to 12 years old, if you don't give enough acyclovir, you will get a disease recurrence. So really, for the age group I look after, I will always give 3 weeks worth of treatment. But sometimes adults only get 2 weeks worth. And that obviously that can be difficult because you have to have a line-in for that whole 3 weeks. So it can be problematic because you may have to stay in hospital for 3 weeks. There are some places that you can actually, the antiviral medicine can be given at home, but those places are they're very few because it's a 3 to 5 times a day treatment. What you can do, what I've done over time, again, to try and help patient experience improve, is that what we now have is a version of acyclovir that can be given orally. The original version of acyclovir, basically the reason we give things through the veins is because we get much better blood concentrations. And what we want to do is get enough blood concentration to kill the virus. So acyclovir through the veins does that, but acyclovir mouth does not. So you don't get enough in your blood to kill the virus. But what they've managed to release in the last few years is a version of acyclovir that actually, if you take it by mouth, almost reaches the same kind of levels as if you gave it through the veins. So what we now try and do is give 14 days of treatment in the hospital and then try and get you home a bit earlier, change it to this new pro drug we call, which then gives you the same kind of treatment you get with intravenous acyclovir, but at least you can have it at home rather than being stuck in hospital. But that's only if we feel you're well enough to do that. So again, that's something that's changed over time. And then obviously we're managing complications. Obviously you've mentioned seizures, which we will see, and we'll have to manage those with anti-epileptic drugs or sometimes even more escalation of treatment. Sometimes the children are very drowsy and lethargic and they can't even feed themselves. We will start off with a drip, but remember, a drip only gives you water. It doesn't give you anything else. So that affects your muscles, you get weak, and your growth gets affected. So we try and get nasogastric feeding in as soon as possible, and that at least gives you all the nutrients you need to fight off the virus and get better quicker. And obviously it's not just one person, as you know, who looks after individuals and children with encephalitis. So I'm a paediatrician, so children will often come in under me when they're admitted, and depending on how that child is, we may need some, all of these specialists. So we may speak to a paediatric neurologist who's obviously expert in children's brains. If we feel that we're not getting on top of the infection or there's other things going on that we're not sure is making sense to us from a treatment point of view. We may get an infectious disease specialist involved if, again, the actual presentation doesn't fit with what we would normally expect. Microbiologists and virologists are very important. They get the test results from the lumbar punctures that we do, and they let us know what the results are, and they will often guide us on what treatment they think is useful or not. Because remember, luckily so far at the moment, we've not had that problem, but across the world there are resistant organisms, so organisms that no longer are treated by our standard antibiotics, and therefore we might need to change those, and the microbiologist and the virologist is able to tell us about that. The radiologist is very important. They're the ones who look at the CT scans and the MRI scans. And again, depending on what they see on those, they might be able to give us an idea of what the underlying diagnosis might be. We've already talked about temporal lobe changes for herpes encephalitis, but a lot of the other viruses and other causes will have very specific findings that they can then tell us about. We may need to involve neurosurgeons if there's fluid on the brain. Sometimes what happens is you get hydrocephalus, which means that the fluid that's around your brain, within your brain, sometimes there's so much protein that it becomes like gloopy, so it doesn't flow as it should do. That means it starts collecting and causing pressure on the brain. When that happens, you may need to relieve it, and that's why a neurosurgeon might get involved. Okay. And then obviously, if you're very poorly, intensive care. So from my point of view in hospital, this is what I see, you know, it's a scary time for the family and child, and actually regular nursing and medical staff is there, but we're so busy sometimes that we forget, you know, to talk to parents and reassure them. And it's really important going forward, what we realise is to tell parents you must ask questions every time, because sometimes we think we're making sense and actually we're not, and nobody says anything to us, so we don't realise we've not made sense because we're used to talking how we talk. It's very distressing to see a child who is, to you, normal, behaving very abnormally. And remember, for us to tell the parents, it's not their fault. They don't know what they're doing a lot of the time. Like I said, need to ask questions. That's what we always tell parents. So you must ask questions if you don't understand. And obviously talk to your child. And very important, look after yourself, because you can't possibly look after your child if you're not looking after yourself. So these are sort of things that we now sort of make sure we tell parents, whereas before we probably wouldn't have been very good at doing that. From a rehab point of view, obviously all children should have an outpatient appointment, and in the past I know the Encephalitis Society did some work on this, is that they were discharged without an appointment, which I was quite horrified about. But certainly in our trust, every child with encephalitis must have an appointment in 6 weeks booked before they leave, and that's actually managed at a trust level to make sure that we give good quality care. Because these are the things we look at. We might have treated the easy bit for us, which is just treating the virus with some medicines, but what the families have to cope with is very different then, and there's all these problems that will then go on, which may be short-lived, maybe longer-lived, and actually part of our role is to give that support. And obviously involve the right people, which may be medical, and also obviously voluntary sector like the Encephalitis Society. I won't talk too much about that because we sort of touched on it already. Just remembering for us, travel causes a whole different set of potential diagnoses. Luckily, I've not seen any of these yet, but I'm sure it's only time. And then I won't talk because there's a little bit of a test, but I was just going to just touch on the antibody-mediated ones. These are the ones that I told you about, which are in response to your immune system going a bit awry. And they attack basically parts of your nerves, and therefore your nerves can't work properly, and you get a picture that looks like encephalitis. And that's a similar thing called ADEM, so acute disseminated encephalomyelitis. Again, it's a type of immune reaction that attacks the brain tissue. Okay, so remember the other ones attack your nerves. This attacks the brain tissue, and it's most common in children. And those three are treated generally by suppressing the immune system, because it's your overactive immune system that's causing the problem, with steroids, because steroids are an anti-inflammatory or an anti-immune system drug. And then recovery. Different children recover at different rates. It does require rest. And I think the things parent tells me that why aren't they better once they get home? And it takes time, and there's a lot of uncertainty because we don't know the long-term effects until we keep monitoring them. And that's very frustrating for us as medical professionals because we can't give you a definitive, yes, he's going to be all right, or no, they're not. And it's very obviously frustrating for you. And making sure that we have a gradual return to school and nursery rather than throwing them in. I think Chris is going to talk about that a bit later. So that was me really. There's some great resources here that are available from the Encephalitis Society. If you haven't read these, it is well worth a read. And I'll stop there.